Good afternoon, everybody. It's really a big honor to me to be in this webinar together with Dr. Betsy Keller. So my name is João Winck. I'm a pulmonologist working in Porto, Portugal. I'm also responsible for the two-day CPET program in my institution, which is Instituto CUF Porto. And I'm also running the long COVID and chronic fatigue syndrome clinic also in my institution. So everybody knows Professor Betsy Keller. She's one of the persons that has contributed the most to developing this protocol. And she's a retired professor in the Department of Exercise and Sport Sciences at Ithaca College in New York, but she's still working in the area with this new Pace Forward Foundation, where she is also providing the two-day cardiopulmonary exercise testing program for people with chronic fatigue syndrome. And I'm sure that everybody will profit from the amazing knowledge of Dr. Keller on this area. So without further ado, I would pass to Dr. Keller just to introduce the topic, and then we will do some kind of an informal conversation together.
Thank you, Dr. Winck, for that introduction, and I'm very excited to be here with you and to collaborate because I'm thrilled that you are taking the initiative to bring an increased understanding of these fatiguing illnesses to the medical community in Portugal, but also to help with understanding of what these fatiguing illnesses mean for those who experience them, and also to help improve their quality of life by learning better to manage them. So I prepared a few slides, as has Dr. Winck, to get us started. And I want to begin by saying that as he mentioned, I do the two-day cardiopulmonary exercise test protocol for purposes of disability assessment at the Pace Forward Foundation, and also for purposes of research. So you can go to the next slide. For these fatiguing illnesses, particularly ME/CFS and long COVID, for many with long COVID, we know that post-exertional malaise, or PEM, is the hallmark symptom of the illness. And Dr. Komaroff, long time ago, described PEM as the illness within the illness, because it defines the overarching symptoms and experience that one with ME/CFS and those who experience PEM with long COVID suffer from. And there are many, I would say, guidelines out there or clinical diagnostic criteria out there, but probably the ones that we most adhere to at this point in time are the guidelines from NICE, which simply stated describe ME/CFS as an illness that has many different symptoms that can be triggered or worsened by any kind of effort or activity. And I think that's really important. If you could just click to the next box there, Dr. Winck. Yeah. More in 2015, the Institute of Medicine in the United States put out a report, a consensus document that simply described PEM as the worsening of symptoms after physical, cognitive, and or emotional effort. And I think it bears repeating that we often tend to think of the trigger being strictly physical, and that is not the case, because cognitive work requires blood flow with oxygen. Emotional stressors, whether they're good or negative, also require oxygen, blood with oxygen to address the emotional upheaval. And whenever blood with oxygen is required and you can't get it where it needs to go, it ends up with symptomatic responses. So if you could go to the next slide, please. Thank you. So this was some work that was published a few years ago describing the symptoms that people with ME/CFS typically experience on a daily basis on the left side of the screen, and then the symptoms that they experience following a cardiopulmonary exercise test. And you can see that they're not dramatically different, that the primary symptom in this heat map is, of course, exhaustion and followed by brain fog. And we see that that's very common after the cardiopulmonary test, that temporarily brain fog might be more amplified after that. And there might be some muscle pain and aches, particularly associated with doing exercise that's not customary. But in general, these heat maps of symptoms are not so different from daily PEM to PEM experienced after a cardiopulmonary test. And if you could go to the next slide. Thank you. In the same study, I think there were three main themes. I'm just going to mention this first theme because I think it's, again, so important to emphasize that the post-exertional malaise was triggered by three broad categories of events. And you can see the kinds of things in these three broad categories: cognitive effort here, physical effort, and emotional effort, that seem sort of, nondescript and fairly minor, but could be sufficient in one with ME/CFS and long COVID to trigger a symptomatic response. So for some, listening to music or reading or writing, simply walking around without great effort, if you're on, if you happen to be on a day where you're more symptomatic, could trigger further exacerbation of your symptoms. And then emotionally charged kinds of events, both positive and negative emotions, can trigger your post-exertional malaise constellation of symptoms. So it's really important to understand that, because when we do a cardiopulmonary test, of course, we're focusing on your physical response to that. But even on a low physically active day, if it's a cognitively demanding day, such as trying to do work at a job, that could be sufficient to trigger symptoms as well. So why do we use a cardiopulmonary exercise test to assess for post-exertional malaise? And if you hit the space bar one more time for me, please. I think it's very important to understand that this test protocol is not a protocol that's diagnostic of long COVID or ME/CFS. There are clinical criteria for diagnosing long COVID and ME/CFS. And it goes beyond what we know from a cardiopulmonary exercise test. What we're evaluating with the 2-day cardiopulmonary test protocol is whether or not you experience post-exertional malaise and how that post-exertional malaise event affects you physiologically. So for those of you who are not familiar with a cardiopulmonary exercise test, it's sometimes called a stress test, except a stress test may not necessarily be measuring everything that we measure during a CPET. And what we're assessing is your ability to produce energy to do work, so your metabolic contribution to work output, how your heart and circulatory system contribute to your ability to produce work, and how your pulmonary system assists with the process of producing energy to do work. So it's a real global evaluation of your physiology and the work that you're able to, the energy you're able to produce to do work. And I suggest you think of work as anything from just walking around to jogging or lifting weights or anything. So it's anything along the spectrum of simply sitting in a chair to all-out effort. So this is a little cartoon diagram of what a 2-day cardiopulmonary test protocol might look like. And at the beginning of the test, we start with assessing your baseline ability to produce energy to do work. And something I'll mention later on, probably, I hope, is that it's very important if you do decide to do a 2-day cardiopulmonary test, that you begin the test protocol in a well-rested state. You don't want your PEM symptoms exacerbated. You don't want to come in there after you've been to 2 or 3 doctor's appointments or something that's been cognitively stressful or emotionally stressful. As best as possible, you want to come into this test protocol for test 1 in a well-rested, non-exacerbated state, if that makes sense. And so this is the beginning of the test with the first cardiopulmonary exercise test. In our clinic, we schedule people for a 90-minute appointment. You do not exercise for 90 minutes. You exercise for a few minutes, actually, but to do the paperwork and to prepare you for the test, put electrodes on the sticky things that go on your torso, and explain how the test goes, we allocate 70 to 90 minutes for that test session. The actual time that you're exercising is not very long at all. It's up to you. We want you to work as hard as you can during the exercise test protocol, but in reality, that might be just a few minutes. And even if we were testing a highly trained athlete, this protocol is not valid if it's long. Really, regardless of who we're testing, we want the exercise test to be no longer than 8 to 12 minutes. So it's our job as clinicians to match the amount of work that we ask you to do with your level of fitness or illness so that you're only exercising for a few minutes. We don't want a 15 or 20-minute test with anybody when we do this protocol. So the test generally starts out at a very, very low level. In our clinic, we start them out basically freewheeling. We don't do a warm-up, and I'll explain that later on, but you pedal at a very, very low intensity. You might not even perceive that there's any friction to your pedaling. And then very, very gradually, the work or the friction that you're pushing against on the pedals begins to increase. And it happens pretty seamlessly, but you'll start to notice after a few minutes that you're doing a little bit more work and so on and so forth. And throughout the test, we monitor a number of different things, heart rate, blood pressure, you're hooked up to an EKG, and you wear a face mask because the really important part of this test is also to measure all of the air that you're breathing in and out to be able to evaluate that or analyze that to assess the amount of energy that you're producing to do work. So we're concerned that when you do both of these tests, test 1 and test 2, that the effort that you gave us by the end of the test was maximal, that you were working as hard as you can. The test is not valid unless it is a maximal effort test, and we have certain criteria that we look at to determine that. One of the other things that we'll look at is, were you able to reproduce test 1 when you did test 2? And I'll get back to that later on as well. We'll also determine whether or not your exercise responses, heart rate, blood pressure, ventilation, and so on, were normal for an incremental exercise test, meaning did your heart rate and blood pressure, for example, go up normally in the way that we expect it to go up as the workload went up? We'll monitor your signs and symptoms. Are you feeling lightheaded? Do you have any other pain symptoms or shortness of breath that we need to know about? We monitor that throughout the entire test. And then we take all of that information for both test 1 and 2 and decipher what it means to us. And then 24 hours later, you come back and reproduce or do the same exact test over again. So the important thing about this 2-day test protocol compared to the 1-day test is with a 1-day test, we can measure all of the things I just described, your ability to use oxygen to produce energy to do work, but we can't really evaluate in any way your ability to recover normally following that exertion. So we bring you back on the second day because in most everybody else, healthy individuals, even deconditioned people, their ability to reproduce test 1 on test 2 is quite strong. It's a highly reproducible test within a certain amount of variability. And so we expect that you would reproduce the test as well. And if you're not able to reproduce the test or other abnormal responses appear, then that's information for us about how your physiology is responding to the workloads that we're asking you to do. So in this slide, you'll also see that, and this is data from a study, National Institutes of Health funded 5-year study that we did, where we tested healthy controls and people with ME/CFS using the 2-day cardiopulmonary test protocol. And Dr. Winck will talk about this a little bit later as well, but what we found was that on average, the healthy controls who were not highly active individuals, these are predominantly sedentary people, otherwise healthy, recovered from this test within 1 to 2 days, whereas those with ME/CFS on average took about 12 to 13 days to recover. Some shorter, some longer, but we'll come back to that later on as well. If you could advance the slide, there we go. As I mentioned, many people who are healthy and those with diseases such as cardiovascular disease, cystic fibrosis, all sorts of disease states, when they do 2 tests in a row, they're able to reproduce their test results. And that does not seem to be the case with people who have ME/CFS or long COVID. So how do we take the data from a cardiopulmonary test to assess for evidence of post-exertional malaise? Well, I'm not going to talk about all of these things that we measure during a cardiopulmonary test, but there are a lot of things. And as I mentioned earlier, we know how many of these variables, heart rate, blood pressure, oxygen pulse, all should respond when we do an exercise test, such as a CPET. And when they don't respond that way, we know something's wrong. And so we get information about your cardiovascular system, your pulmonary system, your metabolic energy producing apparatus, the amount of work that you can do during the exercise test. And as I mentioned before, also how you're feeling when you're doing the exercise test and after the exercise test as well. So we get a lot of information from doing a CPET that we can compare against what would normally occur. Next slide, please. So you can just, fully populate that. Thank you. So we do know that because this is a highly reproducible test, that your maximum oxygen consumption or your VO2 peak here should be reproduced on the second test within about 7% or less. And other measures of oxygen consumption that occur at what we call the ventilatory anaerobic threshold, for example, this measure here is a little bit more variable, but we look for you to be able to reproduce that within about 12% or less. We also look at how much work you were able to do by the end of the test. In other words, when you were maxed out, how much work you did when you hit this anaerobic threshold. And then we have a number of other indicators of your ventilatory function, your autonomic nervous system behaving properly or not that we get from an exercise test. And we know how these things should happen or change over the course of an exercise test. And we compare how your measures changed compared to what's normal. Next slide, please. So how do we take this information and put it in a language that makes sense to, for example, an attorney or a lay individual? Well, one of the things that we learned from the cardiopulmonary test is your ability to use oxygen to produce energy to do work. We call that VO2. V stands for volume, O2 stands for oxygen. So the volume of oxygen that you can use during exercise to produce energy to do work is the measurement that we're taking during a CPET. And so once we know that, we can convert your oxygen consumption to your ability to produce energy to do work. And one of the ways of converting that is by calculating what's called the MET level of work. MET stands for metabolic equivalent of task, MET. And in general, a MET is just another measure of oxygen consumption. And it is determined by taking your oxygen consumption and dividing it by 3.5. So one MET is equivalent to 3.5 milliliters of oxygen consumed per kilogram of body weight per minute. So don't worry about these units of measure here, but just know that one MET is equivalent to 3.5 oxygen consumptions. And this was based on research that was done a long time ago, where we learned, and it was done predominantly on males, we learned that the average amount of oxygen consumed to just keep your body alive at rest was about 3.5. So one MET is equivalent to your, roughly equivalent to your resting oxygen consumption or energy needs. So 2 METs would be twice the amount of oxygen you need for rest, and 3 METs would be 3 times, and so on and so forth. So for example, a 10 MET activity would be a pretty vigorous activity. So you can find in the public domain the numbers of METs that are associated with a whole assortment of physical activities. They range from resting, meditating, sitting down, standing up, to chopping wood, to cooking at a stove, and so on and so forth. And this is found in what's called the Compendium of Physical Activities, which is, again, in the public domain. You can just Google that, and you will see these MET levels of activities. And so when I start there with oxygen consumption up at the top here, and then I convert my oxygen consumption to a MET by dividing it by 3.5, I can then consult the Compendium of Physical Activities to determine what your maximum oxygen consumption means in terms of your ability to do work on a daily basis, for example. So I'll give you an example. If your oxygen consumption at maximum effort was 35 mLs per kg per minute, that would be the equivalent of 10 METs. I could go look in the Compendium of Physical Activity and say, okay, what's a 10 MET activity? And I would find that running at a certain speed would be about what the 10 MET activity is. So I can also find what the MET level of activity is for lower intensity workloads. And which is not uncommon in patients with long COVID or ME/CFS, their maximum oxygen consumption is 5 mets or 4 mets, I would find that simply walking around an office space on a daily basis is pretty close to 4 mets. It's a little bit less than that. But if 4 mets or 3.5 mets to walk around an office space during a daily activity at your job, it places you at your maximum effort. Clearly that's not something you can sustain for very long, because you can't stay at your maximum effort for more than a minute or two. It's just impossible, even for trained athletes. Don't hesitate to chime in, Dr. Winck, at any point if you like.
Yeah, so maybe after this part, I would love to come back to the points that you mentioned that are really specific to PEM, and I would like to have your opinion on the different parameters that we could see. You mentioned VO2 peak on the second, CPAT deteriorating in these patients, and the amount of this deterioration. Are there any good cutoffs for that deterioration to make PEM more likely?
Do you want to address that now, or do you want to come back to that later?
I think that we can do whatever you prefer. I mean, maybe you can still go into the slides and then we can come back.
Okay,
Yeah.
that'd be great. Okay,
Yeah.
sure. So in the US, if you have to show evidence of impairment for disability case, what I found over time is that attorneys generally like to have, in particular, 3 pieces of evidence for their client. They often will ask them to do a neurocognitive assessment, because brain fog, as you noted earlier, is one of those primary symptoms that is exacerbated with post-exertional malaise. Oftentimes they'll ask for some assessment of orthostatic intolerance, or OI. It could be a tilt table test. They're kind of hard to get in our country. Usually people have to wait a while to get them. There is the ability to do an analog test called the NASA lean test, or the lean test, that can be done in the doctor's office, that is far less time consuming and expensive, and certainly can begin to assess whether someone has orthostatic intolerance for a lot less money. And then the third piece of evidence that attorneys like to have is what we learned from the 2-day cardiopulmonary exercise test. So when they're armed with these 3 pieces of evidence, they have a pretty strong case. But I think it's important, and any of you who have been to numerous doctors, probably with ME/CFS or long COVID, trying to get a diagnosis, have learned that you're going to be asked some of these questions over and over again with every physician that you see. And so we always encourage people to come up with some way, not too onerous, not too challenging, but a simple way of tracking their symptoms. And it might just be a simple journal with a number rating of how their morning was and how their afternoon was and how their sleep was, something along those lines. But so some kind of tracking of whether you had a good day or a bad day. And if you can put that on a computer so that you don't have to, so that you can save it and share it with the physicians and not have to regurgitate all of this every time you go to a doctor's office, it's helpful. Putting down your life story of before, what your life was like before, and then after the onset of your illness is also helpful for an attorney as well. And then a simple way of monitoring your activity level, your physical activity level during a day. I know that some clinics will use what they call hours of upright activity. So a percentage or an estimate of how many hours during the day, your waking hours, you spend on your feet. We kind of ask for the converse of that, which is what percentage of your waking time do you spend lying or sitting down? And so again, not your sleep hours, but what percentage of your waking hours do you spend lying or sitting down? So having that information in mind is very helpful for the attorneys, but also commonly asked for when you go to see the physician. And so as far as whether or not, you're doing a 2-day cardiopulmonary test protocol that's designed to assess what needs to be assessed, in other words, post-exertional malaise, there are some what I would call cautionary tales to consider. And one is whether or not the test modality, cycle, treadmill, how quickly the workload changes from the beginning to the end of the test. And of course, not everybody would understand or appreciate this until they've gone through one, but those are things that are important for somebody who's administering this test to understand that the test modality needs to be and protocol needs to be matched well to the person they're testing. And I mentioned earlier that you should not be exercising longer than about 8 to 12 minutes if they've matched the test protocol to your perceived fitness level well. In our clinic, because our protocol always begins at unloaded cycling, it begins at a workload called 0 watts. We do not do a warm up. The first minute of exercise is essentially a warm up for anybody, but we do not do a 3-minute warm up before we start to add friction to the pedals. And what we found with some individuals, especially if they're quite ill, if you do a warm up, you'll actually force them to produce energy at levels that you really wanted to measure during the exercise test. And we'll come back to that. Dr. Winck was referring to that earlier, that you'll actually provoke their anaerobic threshold even during a warm up. And so we do not do a warm up. If you're testing in a clinic that you want to make sure that they're monitoring how you're feeling, not just your physiological responses, but how are you feeling during the test? Are you having pain? Are you having shortness of breath or dyspnea? Any other signs or symptoms that you might be experiencing during the test? Are you lightheaded? Do you, are you having some kind of temperature changes that would not be considered normal, or tremors or anything else? All of those things should be attended to. And then, of course, there's many outcome measures, I mentioned this earlier, that we get from doing an exercise test. Your ability to produce energy to do work, metabolic energy production, your cardiovascular responses, and so on and so forth. I have had some individuals who have asked me to evaluate their exercise test responses because they did them somewhere else. And I don't like to do that because we don't have any control over how the test was administered. But on occasion, I have had people send me their test results, and ironically, there was no measure of blood pressure taken during the exercise test, which is a hugely important measure, what we call a hemodynamic measure. No measure of blood pressure during an exercise test, and in some cases, no measure of what we call RPE, or rating of perceived exertion. So hopefully the tester is asking you how you're feeling during each stage of the exercise test, or at least every couple of minutes. I think I think you flipped back. There we go. Okay.
Sorry.
Uh, and then, of course, your post-test recovery should be monitored. How are you doing immediately after the exercise test? Usually people recover within about 5 minutes right after the exercise test to where they can be sitting upright. But it could take longer with some individuals. We should see heart rate and blood pressure come back down within those first 5, 6 minutes pretty normally. And did you experience any symptoms? And then, of course, we also want to know why the exercise test stopped. In other words, what were the reasons for stopping the test or test termination? And that's important for us to know as well. Okay. Do you want
I
to go
think
through
it's
the data,
over. Yeah.
or do you want to? I know Joan had some.
Oh, you have this case report. I don't know if you want to, or maybe we can discuss a little bit on the protocol and
Sure.
some points. Um, I was wondering, you mentioned that to decide upon the workload, you also match the patient kind of fitness level. But I guess that from my experience, sometimes it's not so easy. Is there any rule that you normally follow just to decide if it's like 5 watts or 10 or 15 watts?
In some of the information that we get prior to the exercise test, so the individuals will fill out forms that we get prior to the exercise test. And we ask them in that health history form whether they were exercising before the onset of their illness and what kind of exercise they did, at what intensity was typical for them, how many days, so the frequency, the intensity, and the duration of their exercise behaviors before they became ill. So we can look at that and see what they did before they became ill. And then if we look at how long they've been ill, if it's somebody with long COVID who hasn't been ill for very long, you might surmise that they have sort of an inherent level, they had a high physical activity history before becoming ill. They have some inherent protection of that high physical activity level and training status that they might bring forward to the test. My experience has been that a 15-watt protocol pretty much captures most everybody who's walking into our clinic.
Okay.
Um, we might not get an 8-minute test out of them. In fact, we might only get a 6-minute test, but we'll get an aerobic challenge out of that. But generally, we don't get much longer than a 12-minute test.
You,
I think I could probably count on one hand the number of times I got a 14-minute test. And I'm thinking back, that was probably from, we had a cyclist who used to do 100-mile cycle rides on a regular basis and
Mhm.
became ill.
Mhm.
And but generally a 15-watt protocol works well to capture pretty much everybody.
Yeah, you also mentioned the importance of measuring blood pressure for this hemodynamic response of these patients, and we know that some of them, have kind of a hypertensive, but also they have also hypotensive responses, which is very much more frequent in these diseases. I wonder if you recommend to do kind of manual measurement of blood pressure, or do you rely on automatic blood pressure devices?
We only do manual.
Okay.
And uh, I was at a workshop a number of years ago with I was a cardiopulmonary workshop with a lot of people who, nurses especially, who administer exercise tests in a wide variety of patient populations, but also with heart failure and people who had pacemakers as well. And the consensus at the table was we do not like auto cuffs because they just did not feel comfortable. Well, with depending on if people have an implanted defibrillator or a pacing device, then the auto cuffs are not going to work well with them anyway. But there are, you know, we've just find too much variability with the auto cuffs that we've not even wanted to go there. And I think it's a good decision because it's very interesting when we're testing that oftentimes we can almost predict when we use an RPE scale of 6 to 20, so the original Borg RPE scale, which is a rating of perceived exertion. It's the one piece of information that you get from the patient about how effortful they feel they're working at that particular point in time. And we kind of joke in our clinic because if we measure blood pressure every 2 minutes, and when we see a noticeable jump, because a lot of them, as you mentioned, are, they have a sort of a hypotensive response and it stays low and then all of a sudden it jumps up. And when that systolic pressure jumps up, they almost always give us an RPE rating of 14, which is around the anaerobic threshold. So it's kind of become a joke in our clinic because we take the blood pressure first and then we ask them afterwards, what is their RPE? And we're all predicting it's going to be 14 and it's almost always 13 or 14. So it's very important to measure blood pressure.
Also, the heart rate, that is also very important, and not only just to make sure that people recover quickly after stopping the exercise, but also as like we were discussing before, as a measure of the limit to exercise. So do you use the heart rate at the anaerobic threshold to define the maximum exercise? And do you normally use the first or the second CPAT for that measurement?
Good question. It's a conundrum, isn't it?
Yeah.
So I'm going to speak first to the long COVID patients that we've tested because we tend to see more reproducibility in the long COVID patients with respect to their maximum oxygen consumption and oftentimes their oxygen consumption and anaerobic threshold. If one of those is going to change on the second day, it would more likely be the anaerobic threshold oxygen consumption. But oftentimes, especially if they were fit and trained before they became sick, we'll see test 1 and test 2 not be very different. This doesn't mean that their tests aren't abnormal, because what we will find is that things changed on how they got the work done or how the energy got produced, particularly on test 2. And I'll come back to that in a minute. But in that case, if they reproduce their oxygen consumption at their anaerobic threshold, doesn't matter which, if the heart rate is the same at anaerobic threshold, doesn't matter which day you use. But normally I would pick the lower one to be on the conservative side. I always recommend a heart rate 10 beats below their heart rate at anaerobic threshold as their heart rate guideline for their activity management on a daily basis. Only because we all know that there's error in measurement. And so I always recommend 10 beats below their heart rate at anaerobic threshold, but then I also try to educate the individual about how this, if they're very good at managing their activity levels and recovery responses and staying below that heart rate at anaerobic threshold, over time, you might see that their tolerance improves. And that's the goal, of course. So that number could change. If for some reason you don't have a cardiopulmonary exercise test to learn what your heart rate and anaerobic threshold is, then I know the WorkWell Foundation has been recommending resting heart rate plus 15 beats per minute as the guideline.
Okay, thanks so much. A very clear explanation. I have the same experience like you were saying on long COVID. I have much less patients on long COVID that have this kind of a VO2 max decrease on the second on test two. So definitely the same experience, and I think that's because some of our long COVID patients they have a phenotype different from ME/CFS, so there are different phenotypes in long COVID. Even though some of the patients complain of PEM, which is another issue that I would like to discuss with you, but because I'm sure that you have the same experience, some of patients with ME that come and say, I mean, and we've seen the questionnaires showing a clear PEM kind of profile. Then we do the 2-day CPAT, and there isn't the pattern that we would expect, like the VO2 max coming down and the earlier anaerobic threshold to count some. So I wonder if you have also the same idea.
Absolutely. Yes, I've seen the same thing over and over again. But when I look at especially the hemodynamic responses on day 2, particularly in these long COVIDs, but you might see it in the ME/CFS as well. And you look particularly at what happened to how did systolic blood pressure change from rest to peak exercise, you notice a difference. And oftentimes I might see what I would call a normal systolic pressure response during test 1 from rest to peak exercise. And then on day 2, we find that their systolic pressure just stays flat. That doesn't change. It might not change for 5 minutes of exercise. It just stays low. I mean, again, we know what a normal response is. We should see a 10 millimeter increase in systolic pressure with every 1 MET level of increase in work. And yet here, their systolic pressure perhaps is, 110 at rest. And then on the first workload, it's 110, which I don't worry too much about because they vasodilate early, when they start exercise. But then we should start to see it go up. And it's still 110 or 112, and then it's 110 again. And then all of a sudden they get to a certain point and it bumps up and it's 138. And so what that means to me is that all of those on day 2, when they're post-exertional, those low level of activities, I'm trying to, apply this to daily living now, but on day 2, if they're post-exertional, those low intensity efforts, walking around your house, doing the laundry, cooking, walking to the bus stop, whatever it is, you're not responding hemodynamically normally. And so it forces you into anaerobicis. And those, when you're post-exertional, what was an activity that was not stressful for you physiologically on day 2 is stressful, and you're anaerobic trying to accomplish that simple activity. And that we see that more often than not on these long COVIDs, but I also see it, with these orthostatic individuals who have ME/CFS as well. And that's the pattern. If you just look at resting blood pressure and max blood pressure, peak blood pressure, you don't see that transition, and you don't see that it's abnormal. That's my opinion. I think that's really valuable information because of what I just said. You can't apply it to daily life, you know. Does that make sense?
Yeah, absolutely, absolutely. The other thing is that I see, especially on some ME/CFS patients, I don't know really which, that sometimes on the test two, they don't have the abnormal responses on the VO2, but they have, abnormal worsening of ventilation parameters like the slope of VCO2, or even worsening of end-tidal CO2 measurement. So do you think that that is because it's different physiopathology, different phenotype, or is there any reasoning, any rationale for this?
Well, yeah, I experience the same thing. And I think what happens is, and I don't have all the answers to this, but because ultimately, when things change like that from test one to test two, I know something's wrong, and I can't always reason it out.
Yeah.
But but the ventilatory function seems to, across the board with MEs and long COVIDs, seems to really take a hit, especially I mean, on test one, it's usually poor. On test two, it can be even worse. And the what I'll call ventilatory efficiency, that VE/VCO2 slope, becomes worse. It becomes higher and higher as well. Um, Not across the board, but certainly in a good number of individuals. And so their ability to exchange gas at the lung level really takes a hit. So is this because, we're not getting, is the blood flow and oxygen delivery, CO2 removal being compromised? Is it a blood flow thing, or is it something that actually happened acutely up at the alveolar level? And I don't know, my gut feeling over more than 20 years of doing this is, if we could get the blood with the oxygen where it needs to go, we wouldn't have brain fog, we wouldn't have skeletal muscle fatigue, we wouldn't have pain, we would have a lot of these things, and we would have better gas exchange. But clearly, ventilatory function is probably it's ubiquitous in this population.
Yeah. Yeah, another technical question, and then we can probably go into more clinical and more practical questions. I wonder if you think that apart from all these standard physiological measurements, that it's the standard CPAT, we could use some extra, blood tests that we could add just to show this PEM or this deterioration on test two. So there are some authors proposing, common biomarkers like lactate, but there are even more complex measurements like these near infrared spectroscopy at the muscle level of oxygen function. And so I wonder if I mean, in the ideal world, if you could add some extra measurements onto your today CPAT protocol, what would you add?
Oh, that's a great question. And in my small mind, uh, what that translates to is, do we have some kind of biomarker that we could just pull blood and see? And I I don't know of any at this point. I know that there are, the German group has done some work, and the Norwegians have looked at lactate, and they have a nice lactate profile study out there. But lactate's quite variable, and to do a lactate profile on an individual, you have to change your test protocol. You can't do what we're doing with the 15-watt 1 minute ramp test, because you have to be able to uh, collect many more samples. to do a good lactate profile. So, and lactate is more variable than you'd like to think, honestly. So it's not worth it to me to put a line in and get bloods for lactate. And I just haven't seen a strong enough signal personally for blood work on patients who are trying to get evidence of, impairment for a disability case. I haven't seen anything strong enough to be able to take measurement from a clinical perspective to help them. From a research perspective, there's all sorts of things that you can look at that are of interest, but to me, and again, I'm probably not the best person to talk to about this, because to me everything else is downstream from the major issue. And I mean, it's you can look at what's going on peripherally in the muscle, but until, in my mind, you can confirm that blood with oxygen has sufficiently perfused the muscle, it doesn't matter to me what's going on in the muscle, because you can oxygen starve a muscle and all sorts of bad things happen. So yeah, I guess I'll just leave it at that. It's probably not the best answer to give you, but I have a little bit of a bias there. So
Oui.
um,
Yeah,
I
yeah.
I just don't feel like, and I'm speaking strictly from a clinical perspective, not a research perspective, that there's nothing driving me to draw blood on somebody at this point to help them clinically with a disability case.
Yeah.
But
Yeah, one thing that also our patients normally ask us is that about the medication. So, should they stop some medications before doing the test, or would you recommend them to keep all the medications? So, could you expand a little bit on that?
that's a great question. We get that all the time, and my answer is always um, this or that. This is, if you, and again, my orientation is that most of the people that we're testing are coming to us to understand what's going wrong with them, and in many cases for disability, to try to develop a case for long-term disability. So uh, my the question I always ask them is, if you want to understand how your body's responding to exercise stress, then don't be on your meds. If And understand that, the post-exertional response could be impacted by the fact that you're not on your meds. If, on the other hand, you don't feel comfortable doing that, then stay on your meds. Do the exact same thing. We always tell everybody, you do the exact same thing before test one with any of your medications that you did before test two, so we can compare apples to apples, so to speak. But if you don't feel comfortable doing that, then stay on your meds and know that what we test is an individual who has benefit of whatever medications they're taking. So your true functional capacity is going to be amplified if your meds are helpful by the medication. But if you really want to know what your true baseline functional capacity is, then you come off your meds for both tests. And
Mhm.
and I'm not a physician, so I'm always very careful to say this is something that you do in, consultation with your physician, and that you do it enough ahead of time that you wash out sufficiently before you get to us for test one. If, on the other hand, we've got, probably beta blockers are the most often used med because of, the symptoms they're addressing. And if I test somebody who's on beta blockers, then I'm very careful to explain the effects of that when I write their report, and how their data can be influenced by the beta blocker.
Mhm. Yeah, very good. Now a more practical question and maybe also very important for our country. So you started doing this protocol for a long time, and I wonder if you know how many centers in the US are also, doing the same for this patient category. What would be your recommendation to make this more widespread? Because at the moment, as far as I know, it's only Haas here. I guess there is probably one other center in Lisbon that also is doing this. And the slots that we have for doing this, it's not huge. So maybe we can only like do this for 6 patients per week. So I mean, considering the very high amount of patients there are, in the real world, just having to have these tests. So, what would be your advice, to make this test more widespread into the pulmonology community or the cardiology community, where I think is the probably the most frequent specialties that are dealing with CPET.
Yes, I understand your question, and it's not an easy answer from my perspective. And not understanding, I don't fully understand medicine in Portugal
Okay.
compared to the sort of medical model in the United States. But the medical model in the United States is about a 15-minute appointment with a practitioner. And of course, that's not going to work in this case. As I said, we spend 70 to 90 minutes with each test session with an individual. And so fitting this into the medical model has been challenging. And I guess it's good for us because we kind of just do our own thing. But there are very few places in the United States who do this test protocol well and provide a report. And that's the other important piece, a report that's not so cryptic that, the attorney and the layperson can understand it. If they just pump out, here are the results of your test, and I've had attorneys send them to me and say, "Can you tell me what this means?" Because we don't know. Uh, so providing a report to help interpret what does all this data mean is a really important piece of the 2-day CPET protocol, of course. And I spend multiple hours preparing each report. So, I mean, I used to spend 10 hours per report, which is ridiculous. And I've gotten it down to about 6 or 7 hours now, but um, it's it's it takes a bit to be able to translate this into something that's meaningful for an attorney who can help a patient or even for other physicians to understand. So I've learned that a lot of physicians, depending on their specialty, don't really understand cardiopulmonary exercise testing. They understand peak VO2 and so on and so forth. So the report's a really big piece of this, and it makes it. And the other part is the willingness to be able to do the protocol as you've been doing it. You have to be careful because you've got to compare apples to apples. So being able to understand enough so that you match the protocol to the person's fitness level and that you um, are careful about how you administer and whether or not you're priming the patient with suggestions or anything. You don't want to be doing any of that between, for test one or test two. You want it to be exactly the same. What I have found, unfortunately, is that there are a lot of clinics in the US and they just do the Bruce protocol. So you know what the Bruce protocol is, right?
Yeah, yeah.
Okay. So they'll put a person on a treadmill and do the Bruce protocol. And I've had patients and attorneys contact me and say, could you tell me if this person, what does this mean? And I say, this means that they did the wrong protocol on this person. And I'm sorry to say, of course, somebody went through this who has ME/CFS, and this is not and they're not even measuring gas exchange. They're just basing oxygen consumption, estimating it off of peak workload. And the workload was, increased so dramatically that they were probably anaerobic in the very first stage. So it's just a highly inappropriate test, but I think probably physicians learned back in medical school about the Bruce protocol and nothing else. And
Mm.
so we still see that happening. And so there are really just a handful of places in the US where this is getting done. And it's a shame because it forces, I mean, we're a big country, and it forces people who are not close to us or are not close to, for example, the Workwell Foundation over on the West Coast. There's a clinic down in Florida that's been doing it, although my concern with them is they don't measure blood pressure, so they lose a lot of information. And so I don't think we're much better off than you are, frankly. I mean, truthfully, I think we're kind of in the same situation, ironically.
I think the time has passed so fast. I mean, we are already at the almost at the end of our talk about our conversation. I'm not sure if Dr. Keller, you want to wrap up or just say some few take-home messages, or should we just stop and or do you want to expand a little bit on some of your points?
Well, I think if you could jump to the slide 19, implications for activity management in MECFS. So just go through all of that case there. There you go. And be able to just discuss this for a minute or two so that those individuals who are dealing with MECFS or long COVID have some information about activity management. Would that be okay?
Yeah, yeah, perfect.
Okay, good. So th- as we all know, post-exertional malaise indicates what we call exertion intolerance, that you did not recover normally following exertion. And one of the things that we've learned over the many years of doing this test, because in our preliminary forms that we have people fill out, we have them rate a number of symptoms before they even come to us. And they often do this several weeks before we see them. Then they rate the symptoms um, when they come to us before we do test one, and then again before test two, and then 4 days after test two. And what we find is that many people with MECFS and now long COVID are simply PEMing themselves, trying to do their activities of daily living. And I don't know that everybody really realizes this, but essentially they're provoking their PEM symptoms, just trying to do their daily life. And I think that's important to understand. What you can do about it is another story, but I think it's important to understand that. Um, in some recent uh, work that we did where we were measuring activity counts or with an activity monitor, we found that MECFS compared to inactive healthy controls on average spend more time in what we would classify as sedentary activities versus light to vigorous activities compared to these controls. No surprise there. Um, that, as I mentioned earlier, that the recovery time for MECFS and long COVID is longer when you do the 2-day CPET protocol and compared to the inactive controls, for example, which recover pretty normally within a day or two. and can take on average about 2 weeks for somebody with ME/CFS. It could take longer, but it's important to understand that to recover from that protocol or just anything stressful in your life, you have to just rest. You have to rest restoratively. And because individuals take longer to recover after an exertional event, that graded exercise therapy, or what we call GET, standard graded exercise therapy, is not going to work for somebody with ME/CFS or long COVID, because that assumes a certain recovery period, and that recovery period is not normal for individuals with ME/CFS or long COVID. It's much longer. Please understand that your PEM characteristics are certain symptoms that are part of your PEM that everybody experiences, but there also can be individual differences in that. And, we've had some individuals come to us who say, I know my worst symptoms are happening 2 days after I exert. And so they know their PEM profile, so to speak. On occasion, somebody will actually stay with us an extra day, and instead of testing them on day 1 and day 2, we'll test them on day 1 and day 3 just to capture that. But even if they say that, usually if you test them on day 2, you'll see abnormalities already. They just don't manifest it until day 3. But those PEM characteristics can vary individually. And understanding the characteristics of your own individual PEM, how frequently or how severely it might happen after an exertional stressor, or how quickly it might happen after that, or the kinds of things that provoke your PEM symptoms, understanding those are the key to avoiding those triggers. And if you just go to the next slide there, Dr. One more. Pace to avoid your PEM symptoms. So I like to end with this slide because I think it's really the take-home point for anybody who's got ME/CFS or long COVID, that the best way to manage PEM is to avoid PEM. And to do that, the way I describe it to people who, especially the long COVIDs, because this is all very new, relatively speaking, for long COVID patients, they're just shocked. They don't get it at all. Whereas oftentimes people with ME/CFS have been living with this for some time and they've figured some of this out. But instead of getting up and thinking you have 20 things to do during that day and you're going to just start with one thing, then the next, that's what I call living linearly. You cannot do that anymore. You have to live circularly. So you get up and you do your one thing, which might be brushing your teeth, and then you recover from brushing your teeth. Lie down, sit down or lie down before you do the next exertional activity. And learning to live circularly, exert, recover, exert, recover, exert, recover. The quicker you can do that and the better you can do that to keep your heart rate below your heart rate at anaerobic threshold, or resting heart rate plus 15 beats, if that's what you have, the better you'll be able to avoid PEMing yourself. And that's the goal here. And then if you can carry that out over many months and get consistent with understanding what provokes your PEM so that you don't provoke it, you may start to notice that you can tolerate a little bit more and a little bit more from an exertional perspective than you could, 6 months or 8 months earlier. Does that make sense?
Yeah, fantastic. Thank you so much. That's a very, very important take home message for everybody. And so I think we should close this session. It was really an honor for me and a pleasure for the time that you had to discuss with us and just to amaze us and give us a lot of information for us to try and settle these 2-day CPAT among our country, to make sure that all the patients that need it can be evaluated and followed through. So thank you so much again for your time, Dr. Keller, and we hope to count on you for the next meetings or webinars. Thank you so much.
Thank you. Thank you for doing this. We appreciate it very much, and to hear your perspectives as well.
Thank you.